Panchajanya, the divine coach of Bhagavan Sri Krishna, which was blown during Kurukshetra, indicating the start of Dharma, Yuddha that followed. The efforts were done for the establishment of Dharma. Dharma was kept over personal relationships and motives. Keeping the same motive in our mind, our organization will work towards establishing the importance and necessity of following and imbibing the culture, accepting our roots, and making people realize the true essence of Ayurveda, not only as a treatment modality but also as a way of life. All these while walking in the path of Dharma. Hence, the motto Shreyam Bharatiyam and Arogyam Ayurvediyam. We have five branches working, such as Team Ashwinas, Team Swami Vivekananda, Team Vedavyasa, and Team Sanjay and the Nalanda. Today we have Dr. Uma B. Gopal Ma'am, Professor and Head of Anatomy Department, SDM College of Ayurveda, and she would be teaching us about the anatomy of the gastrointestinal system. We welcome you, Ma'am.
Good evening, everybody. Today's topic is about digestive system or anatomy of gastrointestinal system. So, according to NCISM syllabus, the time of lecture is 10 hours, non-lecture hour is 6 hours, and practical it is 22 hours. And the subtopics which has to be dealt under the digestive system is describe peritoneum and 9 regions of abdomen. So peritoneum can be asked for 5 marks and 9 region of abdomen can be asked for 5 marks. It is a must to know question. Okay. It can be demonstrated and it can be taken as a lecture. Describe the anatomy of esophagus with relations. This may be asked for 10 marks. With relations, histology and clinical anatomy. Next point is describe the structure of stomach, bed of the stomach, the interior of the stomach, histology of the stomach, blood supply with relations, and clinical anatomy. So, stomach is a 10 marks question again. Describe the structure of duodenum, relations of duodenum, histology, and clinical anatomy. So, everywhere there is histology, and then describe the parts. This is 5 marks question. They may ask a part of duodenum, like second part of the importance of second part of the duodenum, blood supply of the duodenum, or relations of the third part of the duodenum. Like that, they may ask sub questions. So it may take only 5 marks. Describe the parts, structure, and histology and clinical anatomy of large intestine. So parts of large intestine, okay. Here the small intestine is missing. Only duodenum they are given, but you have to understand that it includes the complete small intestine also. That means jejunum and ileum are also included, and it has to be dealt under duodenum. So if at all any lecturers are not dealt, they have to deal with the jejunum and ileum along with the general blood supply, all those. So students, you have to go through the salient features of small intestine, how it differs from the large intestine, difference between large intestine, small intestine, difference between jejunum and ileum, okay, along with detailed study of duodenum. Then comes the large intestine. Describe the parts, structure, histology, and clinical anatomy of large intestine. So here, though the term given is large intestine, the detailed description regarding cardinal features of large intestine has to be dealt, like tinea coli, circulation, appendices, epiploica, like that. Along with that, the specific features of cecum, bed of cecum, appendix, ascending colon, transverse colon, sigmoid colon, descending colon, sigmoid colon, all this has to be dealt under this particular point. Okay. So here also the questions will be must to know questions only. There is no nice to know, okay, desirable to know. All these points are must to know questions. And then describe the anatomy of rectum and peritoneal applications here. So here describe the anatomy of rectum and anal canal has to be taken. So here visceral relations and applied anatomy of rectum, anal canal, histology with its blood supply, venous drainage and applied anatomy. So rectum and anal canal can be studied together. And here also you can see it is the must to know question. What can be asked? Anatomy of rectum, Okay, and the folds of rectum, supports of rectum can be asked. Anal canal, anatomy of anal canal, they will ask in general. As it is a perineal structure, rectum is a structure in the pelvic cavity, like that. So then comes the accessory organs related to the gastrointestinal system. So, describe the structure of pancreas, pancreatic duct, applied anatomy, along with histology of endocrine and exocrine part. So, endocrine and exocrine part histology of the pancreas has to be known by the student. Okay, pancreatic duct means what? Structure of pancreas. Specifically, you see, these points have been given in syllabus itself. So you write off-page notes related to each and every point so that you will never miss what to write in the examination. Then comes describe the external features, anatomy, histology, and clinical anatomy of liver. Usually, they will ask external features of liver. And liver is 10 marks question again, like stomach. Stomach is a 10 marks question. Liver is a 10 marks question. Okay. And esophagus is a 10 marks question. Describe external features and histology of the liver. Next, describe the structure, peritoneal and visceral relations, and histology and applied anatomy of spleen. Spleen is a 5 marks question there. Okay. So, describe the complete anatomy of spleen along with the histology and relations. 5 marks question. There may be MCQ also. So, 10 marks question is also there. 5 marks question is also there. MCQ is also there. So, the total weightage of the marks for the GIT is there will be one must to know question, one MCQ, one short answer question must to know, one long answer question must to know. So total you can prepare for digestive system. Digestive system 16 marks. It will be asked for 16 marks along with Koshtava Masha Sharira. The marks allocation is 16 marks which has been kept there. Okay, so for this you can prepare very clearly regarding that. So next it is the accessory organs of the gastrointestinal system along with the pancreas and liver. They have also asked enlist the salivary glands, describe the anatomy of parotid gland. So salivary gland and anatomy of parotid gland. These are all 5 marks question. Enlist salivary gland, describe anatomy of parotid gland, submandibular gland, sublingual gland with its clinical anatomy. So here also it's a must know question and here it is for 5 marks. And sometimes it may be asked for MCQ also. So this is the topics which has to be dealt. The topics which has not been taken as a subtopics under GI system is oral cavity, the lips, the cheeks, the gums, the teeth, tongue, pharynx. These points they have not given anything in NCSM syllabus. So when I do the class, I will take little bit time to explain this because there may not be questions from this because in the syllabus they are not given. So if they may ask, if they ask also as they are not there in the syllabus, you can claim also. I believe like that. So so from esophagus onwards, gastrointestinal system, from esophagus onwards up to the anal canal, and then the accessory organs in the form of pancreas, liver, and the 3 salivary glands has to be known by the student. Okay, and then spleen has been entered here as spleen is an abdominal organ and it has got its own relationship with the peritoneum. Only in that way it is related. It is not an organ related to the gastrointestinal system. It's an organ related to the reticuloendothelial system. Okay, so now we'll go on with the anatomy of the gastrointestinal system as it is a very large system made up of so many parts together. I'm going to split it. So whatever is possible today for 1 hour, I'll take it and rest of the things I'll take it in the next lecture. Okay, thank you. So we'll start with anatomy of gastrointestinal system. Abhiram? Abhiram? Slide is not changing. Slide change.
ಆಗ್ತಿಲ್ವಾ?
Okay. So the content of the gastrointestinal system, though some of the topics has not been entered in the NCSM syllabus, is the mouth, palate, tongue, teeth. These are the structures along with the pharynx. Okay, these are the structures which has not been dealt. Means it has not been given here. But during dissection, all this will be dealt during dissection of GI system. All this will be dealt in detail along with demonstration and practical dissection. So now going on to the oral cavity. The oral cavity extends from lips to the oropharyngeal isthmus. The junction between the oral cavity and the pharynx is called as oropharyngeal isthmus. It is bounded above by the soft palate and the palatoglossal fold, below by the dorsum of the tongue, subdivided into vestibule and oral cavity proper. You can see here the oral cavity with the tongue, dorsum of the tongue. You can see the soft palate, you can see the hard palate, teeth, the lips. So between the lips and the teeth, the space here which pass deeply is called as vestibule. And this is the wall, posterior wall of the oropharynx, what you can see here. Okay, and this is the palatine tonsils. So what is vestibule now? So it's a slit-like space between the cheek and the gums. Communicates with the exterior through the oral fissure. When the jaws are closed, it communicates with the oral cavity proper behind the third molar tooth on each side. So if you are keeping your mouth shut also, well, in an unconscious patient, sometimes you have to feed. So the teeth are completely fixed. Okay, he cannot open the mouth. So in such a way that when you put the fluid will pass in the region of vestibule. So there is a slight space posterior to the third molar tooth where the fluid passes, and in that way you can feed the unconscious person. Superiorly and inferiorly, it is limited by the reflection of mucous membrane from the lips and cheeks onto the gums. So this region, can you see here? So this region outside the teeth, but inside the cheeks. So it will continue throughout the oral cavity between the lips and the teeth. So this region is called as vestibule. The lateral wall of the vestibule is formed by the cheek. The cheek is composed of buccinator muscle. You can see the buccinator. The name is there. Okay, covered laterally by the skin and medially by the mucous membrane. A small papilla on the mucosa opposite the upper second molar tooth marks the opening of duct of the parotid gland. Next, it is the oral cavity proper. Oral cavity proper, which is the cavity which is present within the teeth, upper jaw and lower jaw. Within the teeth, the proper oral region, what is present, is called as oral cavity proper. Within the alveolar margins of maxilla and mandible, which forms a socket for the teeth. Its roof is formed by the hard palate. You can see here the roof. Roof is formed by the hard palate anteriorly and the soft palate. This is the soft palate projecting like a uvula. This is posteriorly, this is anteriorly. Its floor is formed by the mylohyoid muscle. Okay, you can see here. Tongue is formed by, this is the mandible, this is a genial tubercle, and fanning out of the muscle is called as genioglossus muscle. And deep to it, attached to the mandible, is the mylohyoid muscle. The anterior two-thirds of the tongue lies on the floor. Anterior two-thirds. Posterior one-third, you can see here, posterior one-third is related with the anterior wall of the oropharynx. Floor of the mouth. This may be asked for 5 marks question. Covered with mucous membrane. In the midline, A mucosal fold, the frenulum, connects the tongue to the floor of the mouth. On each side of the frenulum, a small papilla has the opening of the duct of the submandibular gland. A rounded ridge extending backwards and laterally from the papilla is produced by the sublingual gland. You can see here this fold of mucous membrane in the inferior surface of the tongue is called a frenulum linguae, and this is the submandibular salivary gland. Okay, just below it there will be sublingual gland, and this is the duct which is opening out, subduct of the submandibular salivary gland. On either side of the attached portion, the root of the frenulum linguae, you can see the opening through which the salivary dribble into the oral cavity. And this is the tongue, the apex of the tongue. So it has been reflected up to show the structures here. So on either side, it is having the vein and then the nerve. Okay, sublingual vein will be there. Laterally, lingual nerve will be there, which gives a fimbriated appearance to the lateral part of the inferior surface of the tongue. Nerve supply. There are two types of nerve supply. Roof by greater palatine and nasopalatine nerves. Floor by lingual nerve. Cheek by buccal nerve. Okay. Motor, muscles in the cheek and the lips are supplied by branches of facial nerve. Orbicularis, oris muscle, supplied by facial nerve. It is one of the muscle of facial expression. While laughing, while whistling, it is going to reduce the sphincter, means it is going to shut the mouth also. Next, tongue. Mass of striated muscles covered with mucous membrane. It's a mass. Tongue is a mass of striated muscle covered with mucous membrane, divided into right and left halves by a median septa. It is made up of three parts: oral part, anterior 2/3 oral part, posterior 1/3 the pharyngeal part, and it is made up of a root or a base. And it's got two surfaces, dorsal surface and ventral surface. You can see this is the dorsal surface of tongue. This is the basal surface of tongue, and this is the anterior 2/3 in the oral cavity proper, and posterior 1/3 in the posterior 1/3, it is the pharyngeal part of the tongue. This is oropharynx. This is oropharynx. So that which forms the anterior wall of the oropharynx is called as pharyngeal part of the tongue. And this is the region which is the root from here to here, root. Okay, so where it is attached to the floor. So it's having two surfaces, dorsal and ventral. So what is dorsal surface now? It is divided into anterior 2/3 and posterior 1/3 by a V-shaped sulcus terminalis. So the tongue is divided into two parts. See, posterior 1/3. This is posterior 1/3. This is anterior 2/3. So there is a blind depression in the center called as foramen cecum. You can see my cursor going, and there is a sulcus which is passing downwards and anteriorly in a form of inverted V-shaped sulcus, and this is called a sulcus terminalis. So this sulcus terminalis along with the foramen cecum divides the tongue into posterior 1/3 and anterior 2/3. This is completely is called as dorsum of the tongue. The apex of the sulcus faces backwards. Okay, apex means this one, and is marked by a pit called as foramen cecum. This foramen cecum is an embryological remnant which marks the site of the upper end of the thyroglossal duct. Actually, it emerges from the tongue during the development by the two lingual buds and then passes downwards. So from this region, there is formation of the thyroid gland. Then it loses its connection. If it is there, sometimes during dissection we will see, if it is there, it is called as the lingulae thyroidae, like that. So now I am going on to the anterior 2/3 of the tongue. This can be asked under sense organs also. So under GIT also can be asked tongue anatomy for 5 marks. and it can be asked under the sense organ. Tongue as a sense organ related to the taste. So anatomy is one and the same. You have to write this. Anterior two-third mucosa is rough and shows four types of papilla. This is four. Rough. It gives a velvety appearance here and made up of four types of papillae. You can see here velate papillae, foliate papillae. Foliate you can see here. Lines are being given in the form of creases or grooves, okay, which gives a leaf-like appearance. Foliate papillae, valate papillae, cylindrical with the sulcus and on either all the side, okay, just in front of the sulcus terminalis, okay, that is called as valate papillae. Filiform papillae, at conical shaped and filiform shaped. These are the papillary-like projections of the mucous membrane, what you can see in the surface of the anterior two-third of the dorsum of the tongue. Posterior one-third, no papilla but shows nodular surface because of the underlying lymphatic nodules. See here, it looks like a nodule. So this is called as lymphoid tissue present deep to the mucous membrane, giving the appearance like this. And this is called as posterior one-third, but it doesn't have this kind of arrangement, papillary arrangement of the mucous membrane. Ventral surface is smooth. In the midline anterior, a mucosal fold frenulum connects the tongue with the floor of the mouth. Lateral to the frenulum, deep lingual vein can be seen through the mucosa. Lateral to the lingual vein, a fold of mucosa forms the plica fimbriata. So this is the plica fimbriata. Deep to it, the lingual nerve will be passing, and its branching pattern gives this appearance. So it looks dark in color here because of the lingual vein which is passing on either side, and this is the frenulum linguae. This is related to the floor of the tongue or the ventral surface of the tongue. So the muscles, tongue has got two types of muscles. So they may ask five questions, 5 marks question under myology, muscles of the tongue. So under that you have to write the tongue is composed of two types of muscles, or it may be asked in GIT also, intrinsic muscle, extrinsic muscles of the tongue. There are two types. Intrinsic means which is having the original insertion within the tongue. Extrinsic means it arises elsewhere and is inserted into the tongue. So I can see intrinsic muscles here. So superficially deep to the mucous membrane, this superficial longitudinal muscle. Can you see? My cursor is passing. Okay. And you can see vertical group of muscles passing downwards vertically. And you can see this thing, these muscles are passing transversely, so it is in the form of rounded appearance. On either side, it passes into the midline, septum, and helps in transverse muscle, helps in narrowing the tongue and protrusion of the tongue. Long-term muscle coat, whenever it is going to contract, it helps in making the dorsum of the tongue concave. Vertical muscles makes the tongue flattened and broad. Then deep to it, it is made up of, here it will be coming. So deep to it is the inferior longitudinal muscle. So whenever it contracts, it pulls the apex much more convex. So the dorsum of the tongue is converted into convex, and it is going to occupy the oral cavity. So I can see the internal muscles, same. Extrinsic muscle of the tongue. So there are 4 extrinsic muscles. The soft palate and the bones are related with that, for which it is going to anchor. So the mandible, from the mandible, you can see here, this is the mandible section taken. From the mandible, you can see the muscle fanning out into the tongue completely. So this muscle is called a genioglossus muscle. From the hyoid bone, you can see the hyoid bone here. Okay, from the hyoid bone, it is the hyoglossus muscle, hyoglossus, passing into the tongue. Okay, and then from the styloid process of the temporal bone to the tongue, styloglossus muscle, styloglossus. Okay, and then from the palate From the palate, the muscle which passes is called as palatoglossus. It's not shown here, but the palatoglossus passes from the palate into the tongue. So palatoglossus muscle, styloglossus muscle, hyoglossus and genioglossus muscle. These are the four muscles on either side, 4 plus 4, 8. They insert into the and interlace with each other in the median plane on the dorsum of the tongue, where you can see a groove-like structure up to the apex, and that is called a dorsal septa or the median septa. Through there, where there is interlacing of all these four muscles of the right with the left, helps in movement of the tongue and articulation of the tongue whenever there is a speech. So movement, what kind of movement you can see? Protrusion, genioglossus on both the sides acting together for protruding the tongue. Retraction, pulling it backwards, downwards and backwards and upwards. Styloglossus, upwards. Hyoglossus, downwards and backwards. Depression, depressing the tongue. Hyoglossus and genioglossus together on either side. Elevation, styloglossus and palatoglossus on both the sides acting together. Sensory nerve supply, anterior two-third, sensation, general sensation. If you touch the tongue, that is carried by the lingual nerve. Special sensation is a taste sensation, carried by the chorda tympani, a branch of facial nerve. Posterior one-third, general and special sensations, is carried by the glossopharyngeal nerve. And the posterior most part, which is called as a base, carried by the internal laryngeal nerve, that is the vagus nerve. Internal laryngeal nerve is a branch of vagus which carries sensation from the vallicula and the posteriormost part of the tongue. Glossopharyngeal nerve from the posterior one-third of the tongue and also from the velate papillae. And general sensation, special sensation from the anterior two-third of the tongue, except velate papillae, is carried by the facial nerve and the facial nerve. So you can see here the color shows the cranial nerve distribution, the overlapping of the nerve, facial and glossopharyngeal, lingual nerve for general sensation, chorda tympani for the taste sensation. Motor nerve supply. Motor means movement. Movement is from the intrinsic and extrinsic muscles of the tongue. 8 plus 8, there will be 16 muscles. And not 8 plus 8, 4 muscles completely. On either side, if you take it, it is 16 muscles. Intrinsic muscles, hypoglossal nerve, hypoglossal nerve, okay, last cranial nerve. It is motor to the muscles of the tongue. Extrinsic muscles are all supplied by hypoglossal nerve, except, this is important, this is an MCQ question, except the palatoglossus. All muscles supplied by hypoglossal nerve. Palatoglossus muscle is not supplied by the hypoglossal nerve, but it is supplied by pharyngeal plexus. That means vago-accessory component. Remember? So this you can see here, the dorsum of the tongue, greater carnua hyoid bone, okay, mandible, okay. So here also the ramus of the mandible. You can see the external-acoustic meatus, styloid process, mastoid process. These are the structures what you can see. Blood supply, lingual artery, very beautiful figure is there, you can see. Derived out of the external carotid artery, tonsillar branch of facial artery, ascending pharyngeal artery, veins, lingual vein, ultimately drain into the internal jugular vein. So veins carry into internal jugular vein. Artery is given out by the external carotid artery. So if you write lingual artery, lingual vein, that is enough. If you can't remember all this also, it's okay. You can write lingual artery and lingual vein. Don't write in detail, that word is enough. Lymphatic drainage, you can see that is important because there may be chances of, because of tobacco chewing, there may be carcinoma of the tongue. An ulcer beyond the 30 days, you have to get the checked, there may be cancer. Okay, so you should not keep it as it is and you should not neglect. because it is carried by the lymphatics. Submental nodes below the symphysis menti, anterior two-third, submandibular unilaterally, and then deep cervical nodes. Posterior one-third, deep cervical node, jugulo, it's also called as jugulo digastric nodes. So these are the nodes, submental, submandibular, and jugulodigastric nodes. Then it will carry into the deep cervical chain. Okay, so like that it will be carried. If at all there is inflammation of the lymph node or a carcinogenic condition, there will be enlargement of lymph nodes in the neck and the region of axilla, and that you have to take care of. Functions: four kinds: bitter, sour, salty, sweet. This is related with the physiology. Now I'm not passing into it more. Okay, these are the function done by the tongue: sucking, chewing, swallowing, eating, drinking, all that. Trumpeters and horn and flute players have very well developed tongue muscles, able to perform rapid controlled movement or articulation. So the tongue is very important. Okay. Clinical notes, you can see the tongue tie here, tongue tie. Surgically it has to be repaired. They cannot speak. If you tell them to lift the tongue or retract the tongue upwards, okay, you can see the tongue tie, the frenulum, lingual frenulum, okay, attached to the inner surface of the gum. Okay, so lesion of hypoglossal nerve, if there is a, see, it has rotated to the left side. That means there is paralysis of genioglossus of the left side. So injury, it's ipsilateral. Okay, so tongue is atrophied and wrinkled. Okay, so like that. There may be laceration of the tongue. Now going on to the palate. Palate, there are two types: hard palate and soft palate. Hard palate is anterior and soft palate is posterior, means deep. Soft palate is more muscular, hard palate is bony, lies in the roof of the oral cavity. You can see here, this is the tooth in the midline. This is the hard palate up to here, and this is the palatine process of the palatine bone, horizontal plate of palatine bone. This is palatine process of maxilla, which helps in formation of hard palate, and posterior extension. What is this? This is called as the soft palate, posterior, which protrude in the form of uvula. This is muscular, lined by the mucous membrane. Okay, that is called as soft palate. Hard palate, you can see, lined by the membrane here, endosteum here. Okay, so lies in the roof of the oral cavity, forms floor of nasal cavity. The same thing, forms the floor of nasal cavity. Formed by palatine process of maxilla in front, horizontal plates of palatine bone behind, bounded by the alveolar arches. These are the alveolar arch with the socket for the teeth, boundary of this palatine process of the maxilla of right and left in the median plane intermaxillary suture. What you can see here. These are the palatine process lined by the hard sheet of mucous membrane. Okay, and here you can see this is the horizontal plate of palatine bone. This is the palatine bone, and the palatine process, the maxillopalatine suture, intermaxillary suture, interpalatine suture, maxillopalatine suture. Completely this thing is called as the hard palate. Complete. This is the hard palate, okay, lined by the mucous membrane, which is hardly attached, tightly attached to the underlying bone, flat bone. So posteriorly continues with the soft palate. This is the soft palate here. Posteriorly it will continue with the soft palate, and its undersurface is covered by mucoperiosteum. See, this mucous membrane is also called as mucoperiosteum. Okay, so tightly fixed into the bony palatine process of the maxilla. Soft palate now. This is the soft palate. What you can see here is the uvula and this is the region here completely. Okay, attached to the posterior border of the hard palate, covered on its upper and lower surface by the mucous membrane, composed of muscle fibers, aponeurosis, lymphatic tissue, glands, blood vessels, and nerves. Okay. So, what is palatine aponeurosis? It's a fibrous sheet attached to the posterior border of hard palate, expanded tendon of tensor veli palatini muscle, split to enclose musculus uvulae, gives origin and insertion to palatine muscles. There are five palatine muscles. Okay, so there are tensor veli palatini, levator veli palatini will be there, and then the palatoglossus, palatopharyngeus, and musculus uvulae. These five muscles you have to remember. So you can see here in this figure all these muscles. This is the musculus uvulae, and this is the levator veli palatini muscle. This is tensor veli palatini muscle, and this is the palatopharyngeus muscle, and this is the to the tongue palatoglossus muscle. So like that, there will be five muscles which are related, which constitutes the soft palate, anchoring upwards, anchoring downwards, passing deep to the pharynx, passing and attaching itself in the junction of anterior two-third and posterior one-third of the tongue, palatoglossus muscle, and the single muscle unpaired is the musculus uvulae, projecting deep to the mucosal fold here through the aponeurotic sheath, tendinous sheath formed by this muscle in the median plane, and so that is called as musculus uvulae. And you can see the hard palate forming the floor of the oral cavity, forming the roof of the nasal cavity. This is the turbines, what you can see. This is the nasal nares of the nasal cavity here, and the intermediate nasal septum. Now going on to the sensory nerve supply, most by the maxillary nerve through its branches. As it is a maxilla, related with the maxilla, it is the maxillary nerve. Okay, so greater, lesser palatine nerves, nasopalatine nerve, glossopharyngeal nerve supplies the region of the soft palate. Okay, anytime you can see this figure, more that is sensory in function. Motor nerve supply all the muscles. You see, there is one more MCQ question here. All the muscles except tensor veli palatini are supplied by pharyngeal plexus. Okay, tensor veli palatini is supplied by nerve to medial pterygoid, a branch of mandibular division of trigeminal nerve. It is going to supply here. Next, it's a blood supply, greater palatine artery, lesser palatine artery, sphenopalatine artery, branches of maxillary artery. If you can't remember, write only maxillary artery. Ascending palatine, branch of facial artery. Okay, and then ascending pharyngeal branch of external carotid artery. So if you can't remember, directly write maxillary artery, facial artery, and extra branches of external carotid artery. Like that, also you can write. Marks will be given. Clinical notes, you can see maxilla during the developmental process. If the mandibular process is not fused together in the median plane, there will be formation of the cleft. It is a genetic disease. Okay. Cleft palate, it may be unilateral, bilateral, or median. Paralysis of the soft palate will take place. Pharyngeal isthmus cannot be closed during swallowing and speech because of paralysis. It cannot. While you are swallowing the food, there is no movement of the oropharyngeal isthmus as the soft palate is paralyzed and it falls down. Okay. The deglutition and the last stage of swallowing and deglutition process is the difficult. Next, it is the anatomy of tooth. Teeth of upper and lower jaw. You can see here teeth. Okay. It forms a part of masticatory apparatus fixed to the jaws, upper jaw and lower jaw. Teeth are lip raised only once in human. So we are diphyodonts, means only once. Milk teeth will be there, that will be followed by the permanent teeth. And if that teeth is lost, we are not going to, there won't be regrow of teeth. In non-mammalian vertebrates, it is replaced constantly. Okay, in lizards and all, again there will be regrowth and regrowth so many times. So there are two sets of teeth. One set is called milk or deciduous teeth. Other set is called as permanent teeth. So the difference here is, see, the teeth of the adult mouth are permanent, or it is also called a secondary teeth. Most of them are replaced for primary or deciduous, also called milk teeth. Teeth are lost during childhood. So you can see the arrangement here. Okay, the in central incisors, the lateral incisors. Okay, 78, 8 to 9 canine teeth, premolar, first premolar, second premolar, first molar, second molar, and the third molar. Third molar appear in between the 17 to 25 years, second molar in 12 to 13 years, first molar 6 to 7 years. Like that, there is a slight difference in the upper molar and lower molar related to the eruption of the tooth. So parts of the teeth, MCQ question. Each teeth is made up of three parts. A crown. What is crown? Projecting above or below the gums. A root embedded in jaw beneath gums. A neck between crown and root surrounded by the gums. You can see here. This is the root. This is the crown. This region is called as neck. Structure of tooth is composed of pulp in center. Pulp in center. This you can write under histology also. Loose connective tissue with the nerves and vessels. Pulp in the center. Dentin surrounding the pulp. Calcified material with spiral tubules made up of protoplasmic process of odontoblast, all columnar cells present in the pulp. Enamel covering projecting part of the dentin is hardest substance. Hardest substance, okay, is enamel. It may be asked for MCQ. Made up of crystalline prisms arranged at right angles. What is cementum? Covering embedded part of the tongue. Root of the tongue is attached to the alveolar process by a cement-like structure called a cementum, which resembles bone. Periodontal membrane. Odont means teeth. Peri means encircling that. What's the root in the socket? Acts as periosteum. So, which connects. So, here you can see the enamel, dentine. You can see the pulp with the protoplasmic extensions. You can see the cement. This is the root. There are two roots here. This is the region where the blood vessel is passing. Okay, nerves and blood vessels, blood supply. Okay, and this is the periosteum or periodontal membrane, and this is the white color is the socket, alveolar socket of maxilla and mandible. Different types of tooth, forms of tooth. So you see, this is also MCQ question, or under the anatomy of teeth they may ask, but in syllabus it is not there under GIT. Okay, based on, so it is not must to know, it is desirable to know and nice to know. Okay, forms of tooth based on crown shape. Crown, you can see the shape of the crown. See here, crown shape of the crown. In incisor it is cutting, chisel like. In canines, holding and tearing. In premolars, grinding. Bicuspid, two cusps are there. You see 1 and 2 in premolar. Molars, 4 cusps will be there. 1, 2, 3, 4. Here also you can see 1, 2, 3, 4. There will be 2 square crown with 4 cusps will be there in molar. Molar, 4 cusp. Premolar, bicusp. Canines, conical and rugged crown for holding and tearing. Incisor, cutting. Okay, I am repeating that. important. Various types of crowns you can see in this. See here, 4. Okay, here it is 2. It is rugged. It is tearing type. Battery is running. Sorry. Deepshika? Just a minute. Charger. Charger. Just a minute. Can you see the slide? Hello? Can you see the slide? Hello? Hello?
Oh, hello.
Can you see the
Hello.
slide?
Yes, ma'am. Slide is visible.
Okay. Here you can see the root of the teeth. So you can see 2 roots here. Single root. Okay, large root here for canine. Okay, here also you can see 3 roots related to the molar. 2 roots in the lower jaw, molar. And you can see the single root here. So based on the root, single root, which type of teeth is having single root? Incisors. All these are MCQ question. Single root for incisors, canines and premolars. Exception. Upper premolar will be having bifid tooth. Upper molar have got 3 roots. Lower molar will have 2 roots. So this is about the types of tooth and their differences between the distribution among types of tooth. See here very clearly. This figure you can draw in the examination if at all it is asked. The blood supply, alveolar artery and its branches, alveolar vein, nerve here, alveolar nerve. Okay, this is the pulp space. This is the dentine. Okay, and made up of columnar epithelium. And this is the cementum, periosteum. This is the alveolar process of maxilla or mandible, and this is the gums, and this is the enamel, the hardest structure present in the body itself, enamel covering the projecting part of the dentine. So together it is called as crown, and this region is the neck, and this region is the root of the tooth. So dental formula is one such question, or it may be asked for the MCQ. In milk teeth, right upper, right lower, left upper, left lower, 212, 212, 212, 212. Upper jaw, lower jaw, upper jaw, lower jaw. Total 10 in upper jaw, total 10 in lower jaw. But 212, 2 incisors, 1 canine, 2 molars. Like that. Here 2123. 2 incisors, 1 canine, 2 premolar, 3 molar. Like that on right side and left side. So it is about 16 in upper jaw and 16 lower jaw related to the permanent tooth. Next, eruption of the tooth. Deciduous 6 months to 2 years, permanent 6 years to 25 years. Lower jaw tooth is slightly earlier than the upper jaw, approximate age of eruption. So this is the eruption of the tooth, already dealt in the figure. So I am skipping this. Nerve supply, upper teeth, posterior superior alveolar nerve, lower teeth, inferior alveolar nerve. This is enough. So as it passes, it divides into posterior, middle and anterior, like that. Gives out the branches, passes into the each root and supply. Inferior alveolar nerve is derived out of mandibular nerve. Upper jaw supplied by the superior alveolar nerve is derived out of the maxillary nerve. Based on the process, very easy to remember. See the nerve supply of the tongue. Observe the yellow colored nerve passing. You can see the trigeminal nerve also there. Okay, made up of three roots: ophthalmic, maxillary, and mandibular. You can see the maxillary of it is passing through the inferior orbital foramen and then distributing, and mandibular nerve passing through the foramen ovale and foramen rotundum. These are the two openings through which it is passing from the cranial cavity out and extending to supply into each root of the teeth. Blood supply to the teeth, maxillary artery. You can see there. Development of the teeth. It is there comes the histology. You can write this in histology also. Histology of teeth. Okay. Formed in relation to alveolar process, epithelial lining of alveolar process, thicken to form dental lamina, proliferate and form enamel organ. Mesenchyma underlying enamel organ is of neural crest origin and is called dental papillae, together called as tooth germ. Enamel is formed by ameloblast cells, dentin by odontoblast cells, cementum by cementoblast cells. This much is enough. Rest of the mesenchymal cells form pulp of the tooth. Next, anatomy of the pharynx. This is also desirable to know, nice to know. It's not given in the NCSM syllabus, but there may be chances of MCQ. Pharynx is situated behind the nasal cavity, the mouth, and the larynx. It is 12 to 14 centimeters, divided into nasal part, oral part, laryngeal parts. Its upper wider end lying under the skull. Its lower narrow and becoming continuous with the esophagus opposite the sixth cervical vertebrae, lower border of sixth cervical vertebrae. So this is the pharynx from here: nasopharynx, oropharynx, laryngopharynx. This is the thyroid cartilage. Okay, this is the hyoid bone, epiglottis, thyroid cartilage, cricoid cartilage, lamina of cricoid cartilage. Up to here it is cricoid cartilage and this is the sixth cervical vertebra. So this part is called as laryngo. This is the inlet of larynx. So this is the complete from here to here. It is the posterior wall of pharynx up to here. The lamina, lower border of lamina. Cricoid cartilage will extend in the form of lamina. So this is the uvula, this is the oropharynx, this is the epiglottis, lined by the mucous membrane. And the cavity here is called as vellicula. This is the foramen cecum, this is the sulcus, dividing the posterior part from the dorsum of the tongue. In the nasopharynx, you can see the eustachian tube, opening of auditory tube, which leads into the mid-ear cavity. These are the tracheal cartilages, and that is a trachea. This is trachealis muscle, and this is the esophagus. So, not much description I am going with. The pharynx has musculocutaneous wall, which is deficient anteriorly. It is replaced by the posterior opening into the nose, the opening into the mouth, and the inlet of the larynx. So, by means of auditory tube, the mucous membrane is also continuous with that of tympanic membrane. All this I have told you. Skip. Muscles of the pharynx. There are two types of muscle: longitudinal muscle and circular muscle. Circular muscles are superior constrictor, middle constrictor, inferior constrictor. Longitudinal muscles are stylopharyngeus from the styloid process. Salpingopharyngeus from the opening of auditory tube into the nasopharynx. And then palatopharyngeus from the palate. So you can see from the opening of auditory tube, salpingopharyngeus, longitudinal muscle. From the soft palate, palatopharyngeus muscle. And from the styloid process, there will be stylopharyngeus muscle. So constrictors are smooth muscles. Constrictors are circular. This is the superior constrictor, middle constrictor, and the inferior constrictor muscles. So this muscle, this and this. So altogether, it constitutes, it will pass fan out completely. So encircles completely. It's a muscular tubular structure, pharynx. So oropharynx lies behind the oral cavity. The floor is formed by the posterior one third of the tongue and the interval between tongue and epiglottis. In the midline is the median glossoepiglottic fold. On each side, the lateral glossoepiglottic fold. Depression on each side of the median glossoepiglottic fold is called as vallicula. That I have told you already. Okay, this depression is called as vallicula. Okay, this is the palatine tonsil. This is from the palate to the tongue, palatoglossous muscle, and the fold of mucous membrane covering it. This is fold of mucous membrane covering the palatopharyngeus muscle, and this is the auditory tube with the salpingopharyngeus muscle here. Okay, so these are the turbines lined by the mucous membrane called as concha. So lymphatic tissue of the pharynx. At the junction of mouth with the oral part of the pharynx and the nose with the nasal part of the pharynx are collections of the lymphatic tissue. They are of considerable clinical importance. The palatine tonsil, the nasopharyngeal tonsils are most important lymphatic tissue which is present in the pharynx. So next is the applied aspect related to the pharynx. A peritonsillar abscess is caused by the spread of infection from the palatine tonsil to the loose connective tissue outside the capsule. It's called as quinsy, related to the soft palatine tonsil. The nasopharyngeal tonsils or pharyngeal tonsil consists of a collection of lymphoid tissue beneath the epithelium of the roof of the nasal part of